So I'm going to introduce the next chair of the session, Dr. Hedvig Hricak, and she's an emeritus member of the Memorial Sloan Kettering Cancer Center. She's a leader in radiology. She served as a chair for many years in the Carol and Milton Parry chairs, and she's involved in a lot of scientific protocols, and she's very well known. Thank you. There we go.
Wow. Okay. Thank you. Good morning, everybody. It's really a pleasure to be here. And the MAWA title for the session is Imaging to Impact. And I just want to take 1 second to say thank you to our organizers, Professor, I can see you kind of, Hussein Al-Hushi, the president of AMSTRO, Saiful Haq, professor who you know very well, and Dr. Nadim Pervez. They had a dream, and there was from dream to impact, and it's a wonderful meeting. Thank you. We're going to concentrate on implementing the 78 WHA Assembly Resolution for Cancer Care in AMSTRO region. I come from the world of radiology, and you may say, how can we say imaging saves lives? But we paraphrase, your hands cannot hit what your eyes can see. And imaging, especially in radiation oncology, we are your eyes to target, treat, and do adaptive therapy. And we do save lives. This is from the Lancet Oncology Commission on Imaging. If in the 2020 to 2030, if we don't do anything, there will be 76 million deaths worldwide, globally. If we scale up treatment only and quality of care, we do save lives. But we add imaging and provide continuum of care, then we save many more lives, 9.5 million, which is 12.5% of cancer deaths worldwide. This is where investment is important. This is 12.5 globally, but if we look at Africa, then the impact of investing in continuum of cancer care saves 35.7 lives. Now, when we talk to the government and policymakers, they really want to know return on investment in money, in dollars, in economy. So for every dollar invested, if we invest in treatment and imaging and diagnostics, we save $12.45. Africa, it's almost double. And SAARC countries, since this is a part of AMSTRO, the return on investment is even greater. So what is the bottleneck in investing? Is it just the money? No. The greatest bottleneck today to improving cancer care is actually oncology workforce. And in the oncology workforce, those are the data that were just accepted in Lancet Oncology. The greatest bottleneck is diagnostics. Diagnostics include imaging, pathology, and laboratory medicine. We say the world is green, and certainly most of the AMSTRO countries are the greatest deficiency is diagnostics. So we need to really think how to invest in the workforce for diagnostics. It's not just physicians, it's technologists, laboratory technologists, nurse practitioners, everybody that works in the field of diagnostics. Because imaging is a part of diagnostics, we had a very audacious dream. we said, let's make sure that imaging is recognized at the WHO, and therefore the member states will pay more attention to imaging. So propose the resolution on strengthening medical imaging. The team is multidisciplinary and multinational. So every resolution has to be sponsored by country. And we were very lucky that the Ministry of Health for Cameroon sponsored our resolution. It was accepted by WHO, and it was co-sponsored by Ministry of Health from both Latin America, Colombia, and Brazil was leading, Asia, as well as Africa, Burkina Faso. It was supported by IAA and 16 non-state actors. And then we reach out. And it's interesting when you reach out and you collaborate, how much you get back. We received superb endorsement from IAA, from Julie, from ASCO, from private foundation, and then from 8 of the ministries, leaders from Africa. The 3 of those are now present at AMSTRO, and the videos that they recorded in support of imaging and diagnostics are absolutely fantastic, and would highly encourage you to look at them. They are on our website on strengthening medical imaging. And on May 24, the resolution was unanimously accepted at the World Health Assembly. Even Nature Medicine, following the resolution, accepted the paper, strengthening medical imaging capacity will save lives. So as we look at AMSTRO, empowering equity, excellent in cancer care, there is no better person that I know than tell us how to go from a resolution to implementation. And that is Dr. Mohamed Fawzi. He's a radiology advisor to the Ministry of Health. He's a head of diagnostic and intervention radiology, I should say, from Egypt. On national, and he also is the head of radiology department at National Hepatology and Tropical Research Institute. Mohamed, those are big words, but what it is about you make things happen. His impact already on the healthcare and diagnostic in Egypt has been absolutely fantastic, and we are very much looking forward to your presentation. Dr. Fawzi.
Good morning, everyone. It's a really big honor to be here. Of course, Professor Hedi gave us this chance, and a great honor to be invited by the AMSTRO to present here. Strategizing the connection between imaging and radiation therapy, opportunities and rationale for implementing the resolution which Professor Hedi just discussed and talked about, approach to implementation in illustrating the steps to be taken. Imaging availability is directly associated with early stage at diagnosis, optimized treatment selection, more accurate staging, improved survival and quality of life. Cancer treatment pathway is from screening and early detection to diagnosis and staging, therapy decision and planning, and then follow-up. And all these use diagnostics and therapeutic machines, as you can all see. No precision oncology without precision imaging. So imaging access equals treatment access. So we want to make it very understandable that diagnostics and therapeutics work together. So we have to start by the imaging, and without the proper imaging, you will never be able to do proper treatment. The connection between imaging and radiation therapy is diagnostic radiology, where there is eligibility, staging, and intent. Nuclear medicine, functional imaging, staging, response assessment, and theranostics. intervention radiology, where minimal invasive oncology therapies are done, biopsies, palliative intervention, and image guiding radiotherapy, which is the main core we're in now, which is treatment planning, target delineation, adapted radiotherapy. Implications for national cancer control. Imaging must move from supportive services to a strategic system investment. Alignment required between cancer plans, diagnostic lists, and reimbursement mechanisms. What are the opportunities and rationale for implementation of the resolution that was presented WHE 78.3, which is strengthening medical imaging capacity, where the resolution as a system level enabler, the resolution recognizes imaging as a diagnostic tool, a therapeutic enabler, a health system strengthening intervention. Explicit linkage to cancer detection, surgery, radiotherapy, and chemotherapy, and alignment with global priorities like the universal health coverage, and NCD control, and SDG 3, WHO diagnostics, and cancer initiatives. Why the implementation is urgent? Cancer incidence is rising fastest in the developing countries and all the AMSTRO region. And late-stage diagnosis drives which higher treatment needs higher treatment costs, poorer survival, and increased health system strains. Persistent inequities in developing countries and the AMSTRO reason. Uneven distribution of CT, MRI, PET CTs, and PET and radiotherapy-linked imaging, urban and rural disparities compounded by workforce shortage, limited integration of imaging into national cancer pathways and universal health coverage benefit packages. What is the strategic approach to implementation of the resolution from our perspective? Number one is governance and policy integration, embedded imaging explicitly within national cancer control plans, radiotherapy and oncology strategies, universal health coverage benefit packages. Establish interministerial coordination, health, finance, digital transform, higher education, because without the coordination of all these ministries, each will be working on a separate island. And this is really, from my perspective, the biggest gap and problem that we have. Assign clear national leadership for imaging governance. Number two, infrastructure and service planning. Plan imaging and radiotherapy as integrated networks, not stand-alone centers. And this is also a big gap that we are facing. And you have to prioritize geographic equity, referral pathways linking diagnostics to treatment, balance fixed, mobile, and regional hub models. Number three, which is digital connectivity and system integration. We have to link imaging platforms with oncology information system, radiotherapy planning systems, national cancer registries, use teleradiology support to extend expertise. Workforce capacity and skills alignment. We have to train imaging and radiotherapy professionals together where workflow intersect, expand competencies in imaging for radiotherapy planning, nuclear medicine, and radiotherapy collaboration. Also, AI-supported contouring and decision support. Safety, regulation, and quality assurance, which is number five. Harmonize radiation safety frameworks across imaging and radiotherapy. Implement dose optimization, equipment accreditation, clinical audit, and quality indicators. Strengthen patient safety governance to reinforce trust, which is really needed. Steps to be taken from policy to practice. Sorry. Step number one, which is the national assessment, map current imaging and radiotherapy capacity, equipment availability and functionality, workforce distribution, geographic access gaps, identify bottlenecks in the diagnostics to treat pathway. Step number two, which is policy and financing agreement, update national policies to reflect the WHE 78 commitment, secure sustainable financing, domestic budget, development partners, and strategic public-private partnerships. Integrated service design, co-plan imaging and radiotherapy expansion, ensure imaging availability at every radiotherapy site, formalize referral and feedback loops between radiologists and radiation oncologists, digital and AI enablement, deploy teleradiology to underserved region. And I think this is one of the main pillars that is really that we as Egypt highlighted and started working on. Introduce AI tools with caution, with clear governance, workforce training, ethical and regulatory oversights. And this is something that is of extreme importance because as we all know, and as our distinguished speaker before me, AI is coming under any circumstance, whether we like it or not. So it has to be properly governed or we're gonna lose control. Monitoring, evaluation, and trust building. Track indicators like time to diagnosis, time to treatment, treatment accuracy and safety. Communicate transparently with patients and the public. Now the Egyptian experience, a quick brief on the Egyptian experience. These are numbers from 2020, where the total population at that time was 102 million. When we had a number of new cases on 134,000, deaths was almost 90,000 from cancer, and prevalent cases 278,000. These are the recorded numbers in 2022 and 2025 and expected numbers of new cases in 2030. As you all see, it is 235,000 cases that are new that are expected to be present in 2030, by 2030. What did the Ministry of Health do? The GDR is the General Department of Radiology, which I am supervising. What's its strategic goal? Expand access to essential imaging services, prioritize basic modalities, mobile radiology units. We started in 2022 implementing mobile radiology units in order to be able to go to remote areas, whether for screening or to do supportive imaging in order not for patients to move or to be transferred. And we started public-private partnerships in oncology, and we had our first triple P collaboration with Gustave Roussy in Egypt. Invest in infrastructure and equipment modernization, upgrade outdated equipment. And this is also a sector that we started in the radiology and also partly oncology, is that we don't just always buy new machines, but we update our currents because the IB, which is the install base, is very big all over Egypt. So you cannot cover the expense of all the new machines. So you can just upgrade what's needed. Centralized procurement. This is very important to have the proper choosing of the proper specifications of the machines that you want to implement. Tiered service model, localized production, manufacturing. And this is one of the real arms that we did in Egypt, that we started local production. We partnered with our fellow companies, and now we're locally producing ultrasound, locally producing X-ray, locally producing MRI, and we're working on the next level that we're locally producing high-end CT. We're going to reproduce even contrast media. Strengthen human resources and training, expand radiologist training, subspecialty training, which is of extreme importance, task shifting, and retention incentives. These are urban hospitals in underserved areas in Egypt, where we just installed new machines like a cath lab, like a CT, and MRI. This is an image of our MRI units. We have 4 CT mobile units that are going around all over the country, and we have 4 CT units and 1 MRI unit, which started working in 2022. And also we leverage teleradiology and digital health, national teleradiology network. We have a PACS system, an AI-assisted diagnostic tool, standardized quality and safety. We have national imaging guidelines, accreditation and audits, radiation safety programs, data research and monitoring, national imaging registry, support local research, and monitoring and evaluation framework. And we launched our teleradiology program because Egypt, we have many hospitals in underserved areas, in urban areas that have lack of radiologists. So we are connecting to the data center 200 hospitals, and we're writing reports for 32 hospitals, and we have 52 radiologists on board working in these 32 hospitals since we started in 2022, and since we implemented our national VNA. And also we have diversity in use of PACS system. We don't have a single PACS system. We have 6 PACS system companies that we are working on with. We have also a very strong quality assurance department. We fully examined the governates 9, and now we're going for 4 and 4. We also have an AI department, which just was launched in 2023. We're partnering with AI companies, and we're working on generating our own AI. And also the head of the AI department is Dr. Ala. She's with me here in Dubai, and we're happy to be here. We have 5 consultants and 15 volunteers who are working with us in the AI department. Just brief, this is my last slide. We have a 5-year plan, because no success happens without putting a clear plan to reach it. By the end of 2023, we will try to 100% fill our gaps, but we are working more to have almost 70 to 80% of all radiology services to be locally produced in Egypt for availability of the service and the machines. And this is our main target in Egypt. Thank you all very much.
That was truly superb, how you can implement. Mark, can you come? Our next presenter is Mr. Mark Stoesz. He's President, Enterprise Solutions, International GE Healthcare, and truly, truly ambassador for global health. Mark.
Thank you, Professor Heddy, and great to be here with you all this morning. So how does industry get involved, and what can we do differently versus what many of us have experienced in the past, which is effectively just buying a piece of equipment, installing it, and then paying over time, hoping that it stays operational for the next 10, 15 years. And that's really been the way in which in the past we've been operating. What are we doing differently now? Well, I would start by looking at focusing more on integrated partnerships with, whether that's a Ministry of Health or local advanced customers, luminaries, to understand where we need to drive the business to be more successful, not for the business, but for the population of the people that we support. We heard some great discussions about education and training. We see a lot of impact that we need to do from that standpoint. So when we look at how GE Healthcare is looking at LMICs, and I think a lot of other OEMs are doing the same aspect, which is shifting from transactional way of working, moving towards longer-term agreements and looking at procurement models that are not the standard, operating, capital expenditure models, but moving into different types of models from a procurement standpoint. And things that I think are really differentiating is starting to move into how do we support education and training as a partner. And as a partner, what I'm thinking about here, and I'll share some examples, is how do we work on building things like innovation hubs in underserved areas? The example I'll give is in Indonesia, where we've developed the innovation hub where we do education and training in collaboration with societies, in collaboration with luminaries, to make sure that we can build up this strength. So I was very excited to hear this morning from Professor Will about the work that is happening in oncology. From our side, we look more towards diagnostic imaging and what we can actually do to strengthen that and going forward. Additionally, it's around the digital tools. How do we develop tools that simplify the way of working? Of course, we have an prepared staffing of availability of people, but how can we actually leverage AI tools and other tools to simplify the way of working together? And ultimately, this is going to lead us to a positive outcome. So this first example on the left is actually a video showing an AI tool for ultrasound. Why is this important? Well, if I take Dr. Fawzi's environment in Egypt, where they've done a very fantastic work in breast cancer earlier detection, where they've reduced just by clinical examinations, reduced by 80% the detection of advanced, or say more advanced cases of disease, stage 3 and stage 4 disease. We've now taken 80% of that out. Why that is important is, what do we do for the next step? So phase 2 of this project is to look at how can we use ultrasound, put it in the hands of non-expert users by leveraging tools like AI. And the example here is an AI tool from another vendor that is one that we're working with Dr. Fawzi and his team to understand whether or not by utilizing this, can we actually downstage even further to be able to address this specific disease. The middle two images, or on the middle and the right side of your screen, are examples of tools that we're looking at in the oncology space. How do we leverage AI tools, make it more use of agentic AI, large language models to assist the oncologist and in your treatment to understand what was the last radiology examination, what was the last blood sample that that patient had, and put it into a longitudinal way so that it simplifies. Instead of going and hunting for the last examinations, it automatically pulls this and puts it into a longitudinal space so that it simplifies the way in which you as physicians and therapists can actually understand that data and bring it to life. And this is helping to reduce the overall complexity and operations in your communities if we implement these types of tools. So our goal is in GE Healthcare is to understand how can we deploy this in markets that are underserved and develop these tools. And for doing that, we do need to move away from the standard models of procurement. We need to start to look at it differently. So yes, we can still offer conventional procurement models where we just sell a piece of equipment. But more and more what we see and what we've experienced in these communities is a different desire. The desire has to be around how do you create a true partnership, whether that's a public-private partnership, whether that's through an NGO, whether it's through a government. How do we build this in a smarter way to create this solution that is really around whether that's a managed equipment where we take care of that equipment and keep it up to date over a 20, 30-year period of time, whether we look at a unitary payment approach where you pay one payment that covers all activities around that system and includes other aspects around training. So for treatment for the operators of these equipments, how do we improve that from bringing experience and leadership trainings? How do we look at change management? In some cases, there's a big change that has to happen when we look at bringing new technology into these markets and making sure the efficiency and utilization of that tool is brought to the state-of-the-art way of working. So from the standpoint of what we're looking at doing with respect to support of the community, it's really around bringing together different procurement models that are different than today's standard way of working, bringing into that education and training, looking at that from multiple different fronts, and then also on top of that, looking at how can we as industry support more the education across these parts of the markets that are underserved. So with that, I think I'll hand back to Hedvig and we thank you.
Thank you. Thank you, Mark. Really, thank you. So, Saiful, I know we are running late. I'm sorry. I thought there were great presentations from the policy-making, government, industry, and then academia. And are there any questions for the audience, from the audience, for any of the speakers? Do you see any? I don't see. We are blinded here. Okay.
There will be time during the coffee time.
Perfect. Absolutely. Yes. Thank you all very much. Thank you.
You don't have any slides for this? I have slides. Which one? This one? Where is it? Industry. Yeah. I'm just in case.
Yeah, take that out.
And then. Do you want presenter view or I do?
Presenter view is fine.
Fine. Okay.
So good morning, everyone. Slide is, blinding. Yeah. If I may have your attention, please. Good morning. Good morning. Okay. So it's not every day that. So if I may have your attention, please. Good morning, everyone. Good morning. Yes, that's what I'd like to hear. Okay. So it's not every day that we are able to pull together the decision makers of the technologies that we use in radiation oncology, in imaging, and in AI. We're actually very fortunate to have those decision makers today on this stage together. The president of Varian Oncology Solution, the CEO of IBA, the executive chairman of Leo Cancer Care, CEO of United Imaging, and founder and CEO of Envision. They're all together. We're very fortunate to have them. And if I may request all of you to please come to the stage, and let's give them a round of applause. I know how challenging it is to get time from all these chiefs, the leaders from all the C-suite level, and really appreciate all of you taking your valuable time from your busy day to come to this launching ceremony of the meeting of AMSTRO. Thank you very much for doing that. Really appreciate that. So during the last year, there was a series of papers published in Lancet on cancer control in the Middle East, and it identified the various the gaps in cancer care. And those are the things that we have been talking about at this meeting: the lack of access to care, equity, financial sustainability, workforce development, and all of that. And there were also the call to action to the industry leaders to co-own some of these responsibilities to bridge that gap. So I'm going to ask a few questions to these our leaders here, based upon what we saw in that Lancet Commission report, and then before you know it, 30 minutes will be over. Since you have only 30 minutes, the way I would request each of you is the following: we'll follow some ground rules, and I'll put a question that I will ask each of you to respond to, and then when you do that, please introduce